I hope that you've had a very interesting day so far. We've had the pleasure of many excellent presentations, and I trust this afternoon's session will be very similar. So my name is Gary Small. I'm the director of the Cardiac Oncology Clinic here in Ottawa. I'm an imaging cardiologist, and with research interest in cardiac amyloid. And I'm joined by my colleague and friend, Nowell Fine. Dr. Fine is based in Calgary and probably needs no introduction to many of you there. Hi, Nowell. Can you hear me okay? Yes, he's nodding well. So we have two, I want to keep ourselves to time if I can. So we have two case reports to get us off, set off this afternoon. And in slight change to the program, we're going to start with Dr. Hijazi, Waseem from University of Calgary. Dr. Hijazi is a PGY6 adult cardiology fellow in Calgary, and he has an interest in multimodality cardiac imaging. And he's going to be looking to doing more cardiac CT and MRI changing after his as part of his fellowship. So I don't know if Waseem's there, and if I can encourage him to take over the screen.
Don't see Dr. Hijazi on just yet.
We are.
Yeah. See if I can connect with him. Sorry about this.
That's okay. So the goal is to do two cases. We'll just see if we can get in touch with Dr. Hijazi, but we'll do the two cases one after another. And then we have a special treat from North York General Hospital. Dr. Kareem Morant is going to be presenting some common genetic variants in ATTR amyloid. So we're going to focus really in the second part of the session on familial or inherited ATTR cardiac amyloid. And then at the last talk will be a presentation really looking at gene carriers of variant ATTR cardiac amyloid. And we focused on that particular type of cardiac amyloid because these patients really are the rare types of amyloid that we see in practice. Wild type is much more common, and but the variants do come up in clinic. Thanks, Nowell. I don't know how you're doing. No.
I just sent Dr. Hijazi a note. I think he was expecting to start at 35 past the hour sharp. So I have 33 minutes. So he may be cutting it close to the wire here. So hopefully he'll join us in a minute.
No. For those who don't know you, do you want to just say a little bit about what you do out in Calgary and in terms of the amyloid service? I can speak for Dr. Fine. He's done a great job in terms of putting amyloid on the map in Canada, and he's already spoken today about pan-Canadian registries. But perhaps just give us a bit more of an update about how things are and what you're up to in Calgary whilst we wait.
Thanks. Yeah, thanks. And thanks for inviting me to co-chair. Well, I see actually Dr. Hijazi is just logging in here. Waseem, actually, we are ready to start. If you're able to load up your slides. Dr. Small, perfect. Dr. Small has already introduced you. And so, yeah, we're looking forward to your case.
Thank you for the introduction, Dr. Fine. Can you see my slides okay?
Yeah.
Okay. So my name is Waseem. I'm one of the cardiology fellows in Calgary. I have a case here today where the objectives are as follows. We'll be reviewing the basic clinical presentation of cardiac amyloid and its subtypes. I'll introduce a case of cardiac amyloid complicated by aortic stenosis, and I'll discuss unique considerations in valvular intervention in patients with cardiac amyloid. So first off, just to review what the pathophysiology of cardiac amyloidosis is. Fundamentally, it involves the deposition of proteinaceous material inside of myocardial tissue, which is misfolded. The two most common causes of cardiac amyloidosis are AL amyloidosis and transthyretin amyloidosis. AL amyloidosis involves light chain deposition from immunoglobulins, and it's a plasma cell dyscrasia with specific hematological treatments. Transthyretin amyloidosis is misfolding of a protein which is normally produced by the liver, and there's two major types of that: wild type amyloidosis and hereditary amyloidosis. These patients typically present with a restrictive cardiomyopathy picture and sometimes also valvular dysfunction, conduction, and arrhythmic abnormalities can be seen as well. On the right here, we have a pathological specimen of amyloidosis, and you can see both the right and the left ventricles are thickened and hypertrophied. On the right, we have Congo red staining of a histological specimen that shows deposition of proteinaceous material in the interstitium. Fundamentally, these patients will often present with a restrictive cardiomyopathy picture due to diastolic dysfunction, pulmonary hypertension, and congestive heart failure. They often do not tolerate vasodilatory therapy well and do not tolerate beta blockade. Autonomic dysfunction and conduction abnormalities are also frequently seen. So I'd like to introduce the major study which demonstrated that cardiac amyloidosis often coexists in patients who are elderly and undergoing TAVR. In this study of patients who underwent TAVR and then were subjected to a pyrophosphate nuclear scanning to assess for amyloid deposits, 1 in 8 patients had transthyretin cardiomyopathy. And they list here specific factors which may heighten the suspicion of this, including increased wall thickness, left atrial enlargement, and also the presence of low flow, low gradient aortic stenosis. These factors are also highlighted in the Canadian 2020 amyloid guidelines for suspicion of cardiac amyloid in different clinical scenarios. This particular case is a 75-year-old man. He was followed in Calgary's cardiac amyloidosis clinic. His profile is that he's had a bicuspid aortic valve, and it was replaced in 2011 because he developed symptomatic severe aortic stenosis at that time. He also had mild ascending aortic dilation with a diameter of 4.3. Decision was made to replace it as well with his surgery in 2011. He had done quite well with this, but then developed heart failure symptoms in 2021 despite the well-functioning valve. He had an echo that showed a thickened wall, and then following up with that, had a pyrophosphate scan that demonstrated he had transthyretin amyloidosis. He was then placed on tafamidis therapy, given his positive life expectancy and functional status at that time. Other factors to note: he had normal coronary arteries. He had paroxysmal atrial fibrillation with a CHADS 265 score of 2. And he had also unprovoked DVT and PE in 2020. This was with 12-lead EKG. He had atrial fibrillation with borderline ventricular response, Q waves in AVLN1 consistent with a pseudo-infarct pattern, and also the classic low voltage despite increased LV mass, with his limb lead voltages being less than 5 millimeters. Interestingly, he had a rapid progression in echocardiographic findings that correlated with his symptoms. When he first came to the amyloid clinic in 2021, he had normal bioprosthetic valve function. His Vmax was on the higher side of 2.8, but that was stable. And he had moderate biventricular dysfunction, but at that time was asymptomatic. He was started on tafamidis, and then on repeat echocardiogram in September 2022, his velocity across the valve had increased significantly to 3.8, despite no change in his ventricular function. He continued to be asymptomatic at that time, and so he was followed, but he did become symptomatic in 2023. At that point, he was referred for a valve replacement, and TAVR was considered the best option for him given elevated surgical risk otherwise, and he was deemed a candidate for a valve-in-valve procedure. This was his echocardiogram before the TAVR, and his peak velocity had increased further to 4.2. And also of note is the fact that his ventricular function had severely declined as well. It had now been approximately 15 to 20%, and his RV was also still moderately dysfunctional. He had developed severe TR. He nonetheless proceeded for a TAVR, and the procedure itself was technically successful. He had an evolute valve deployed in the aortic position with a good technical result. He had no hemodynamic complications relating to the valve deployment itself. However, during the procedure, he had severely altered level of consciousness and developed right-sided dense hemiparesis. He was promptly intubated and then transferred to our CCU. He had an urgent CTA and stroke activation. The stroke team performed EVT, and he had clot and thrombus removed from the A2 and M2 branch culprit occlusions. He was promptly extubated in the next 24 hours, and after a week and a half of rehab in the hospital, was discharged home with no focal neurological deficits, which was a very positive outcome given his dense hemiparesis that we initially saw. So I took the time to do an analysis for what the outcomes in TAVR were for amyloidosis patients who underwent TAVR. There was recently a large retrospective analysis of 250,000 patients across 30 US states who were hospitalized for TAVR, and 273 of these had confirmed ATTR amyloid, which is likely an underestimate based off of prior analyses. And not everyone in this study was tested for amyloid. However, those who did have amyloid had a higher risk of periprocedural stroke associated with TAVR, though their outcomes and short-term mortality were the same. So I think this case highlights a few important points regarding valvular intervention in patients who have cardiac amyloidosis. One is that the literature currently reports that up to 1 in 8 patients undergoing TAVR have cardiac amyloid, which is important to consider, given that they may have unique medical management issues. Second, in an area that's not well understood, is that these patients may have different rates of structural degeneration due to how the amyloid fibrils may impact the valve and potentially deposit on that valve. And third, specific strategies regarding stroke risk mitigation may be needed. We do know that in general, patients with amyloid are more thrombogenic. They have atrial electromechanical dissociation, and these patients normally deserve anticoagulation for AFib, regardless of their CHA2DS2-VASc score. I think there's lots of future research areas that could come out of this, looking at the durability of TAVR versus SAVR in AS patients, and also looking at anticoagulation indications in these patients and how tafamidis may in fact impact outcomes. Thank you.
Great, thanks. Pardon me. Thanks, Waseem. That was a great case, interesting case, and I think we have a minute or two for some questions and discussion. I know this patient well, of course, from our center, and a few interesting aspects. He did have a bicuspid valve, so we often wonder, what's the chicken and what's the egg, because we know of this association. But with him, it certainly his diagnosis of ATTR came, more than 10 years after his bicuspid valve was replaced. So we think, that's just kind of bad luck that he had two things happen to him. These patients are challenging. I mean, it's a nice case to highlight the increased risk of procedures in general, but TAVR in this population. In our ATTR patients without aortic stenosis, we often, or not maybe not often, but we do see their ejection fractions drop for reasons that we're not quite sure of, even though they seem to be clinically stable. So sometimes it's hard to know what's causing what. Is it the amyloid? Is it the aortic stenosis? Are they both aggravating each other? This patient's EF dropped and the gradient was getting worse. And so that made us feel like we really needed to go ahead and do TAVR. And fortunately, it turned out okay. In general, indications in ATTR for TAVR are similar to those in other patients, just recognizing that there is this risk profile. So are there questions? Any questions from the group? Or
if I can, Waseem, it's Gary Small. Thanks, Noah, for that kind of summary of the case. You've seen great job presenting. I just wondered, locally, with your interest in multimodality imaging, or perhaps Noah can also comment, is, are you doing anything specific to screen your TAVR population? You'll probably be aware of some of the literature on this, but is there anything that you're doing specifically to look in patients who are being referred for TAVR to look for coexistent ATTR? Is there anything you're doing in terms of echo, any routine MR, any routine use of pyrophosphate? Are you aware of any of those things?
Yeah, I can take that. Waseem, might be tough for you to answer that. So, we've certainly engaged with the TAVR program and chatted with them and had some conversations a few years ago about different strategies. But I think what a lot of TAVR programs experience, ours as well, is they're extremely busy, and their ability to do screening through their own clinic machinery and systems is quite limited. They've just got a lot of patients, a lot of work, a lot of testing, and so other than just saying, hey, these are the red flags, please keep a lookout for it, we hadn't done anything formal until recently, actually. It was suggested to us by some of our colleagues actually in Quebec. Dr. Francois Tourneau had described what they do, whereby they have their amyloid clinic do the screening of patients for them. So they let the TAVR clinic lets the patient know that they're at risk for this condition. There's an amyloid clinic. They'll be looking at their records, and they'll be calling them if they feel that they warrant further screening. And that kind of takes it off the shoulders of the TAVR clinic and puts it on to the amyloid team to focus in, which actually makes a lot of sense. So we're just starting to roll that out now, so I can't tell you how it's going. But that's our experience, and that's going to be our approach.
Thank you.
Good. Well, unless there's any other questions, I think we can move on. It's Dr. Mengesha.
Hey, Nowell, it's Kareem. I have a question.
Okay, go ahead. Yeah, I think we have time
So I know, I'm pretty sure you're aware, and you had highlighted there, Waseem had highlighted about the risk of stroke in these patients. Are you doing anything specific in terms of stroke risk? I know patients with AFib, cardioversions, are you ensuring that you do TEs beforehand, even if they're on anticoagulation, or what's your threshold with that? Because I do struggle with that to some degree.
Yeah, so that's separate. That's just ATTR in general, not aortic stenosis specific, right?
Exactly. Yeah. Sorry.
Yeah, we do that, and that's been the prevailing, TEE before cardioversion, and trying to screen for atrial fibrillation for those who are in sinus rhythm. We do that with Holters. It's not very effective, but we haven't come up with something better that the patients will actually want to do. I have some colleagues, in the US who are now starting to poo-poo that TEE before cardioversion, regardless of anticoagulation. They think it's overkill. And I can certainly see that. And it's rare that we have to cardiovert, or it's rare that we do cardiovert. So I haven't actually come across that yet. Will I be brave enough to take the jump and just cardiovert them without TEE? I think so. I've heard it from enough colleagues around the world to suggest that, maybe TE is not necessary and we can treat them just like other AFib patients. But I haven't had the chance to walk the walk, if you will, just yet. That makes sense.
Understandable. Thank you.
Yeah. Okay. Thanks, Kareem. Great question. Okay, let's move ahead. So next we have Dr. Betty Mengesha. My pleasure to introduce Dr. Mengesha. She is a cardiac imaging and research fellow at the Ottawa Heart Institute. She graduated from Jimma University Medical School in Ethiopia, and then completed internal medicine residency and cardiology at Shamir Medical Center in Israel. Her main interest in research projects during her fellowship focus on the role also of multimodality imaging in cardiomyopathy and structural heart disease, and has a great case for us. So take it away, Betty.
Okay. Thank you all. So I'll be presenting in short about a less clinically encountered entity, isolated atrial amyloidosis. I have no disclosures. So I'll present a 62-year-old male who had a prior history of ascending aortic replacement with aortic valve repair for type A aortic dissection years ago. He later on had an AV and RT ablation and a pacemaker implanted for a new onset AFib with slow ventricular response in the context of a known AV nodal dysfunction. Later on, he underwent valve replacement and bypass graft, and at the time, left atrial appendage was excised. ANP amyloidosis was diagnosed on a routine surgical pathology, and it was confirmed on mass spectrometry. Patient remained asymptomatic, but on imaging, both echo and cardiac MR, patient had LV hypertrophy, LV dysfunction, biatrial enlargement. He also had a mild troponin elevation, and he ended up being sent for a PYP scan. So my question to the audience is, which one of the following is true regarding ANP amyloid? I don't have a poll, so I'll give you a few seconds to think about the answer. Option A says it's associated with atrial fibrillation and affects atrial conduction. Option B, men are affected more than women. Option C can be accompanied by LV myocardial amyloid deposition. Option D, it can be detected by PYP scintigraphy. Okay, so isolated atrial amyloidosis is actually believed to be the most common type of amyloid, although it's rarely diagnosed. It's been shown to be present in up to 85 to 90% of patients at the age of group of 80s to 90s. It's characterized by a localized infiltration of the atria without involving the ventricles or other cardiac structures. And amyloid deposition is more frequently seen in the left than the right atrium. And it correlates with atrial fibrillation duration and female gender. So isolated atrial amyloidosis has been reported in up to 39% of atrial tissue specimens from patients with valvular heart disease and those that have persistent atrial fibrillation. Patients with long-standing atrial fibrillation and rheumatic heart disease were diagnosed with and were found to have a higher prevalence of this condition. So the main constituents of the amyloid fibril in this entity are ANP, the atrial natriuretic peptide, and the N-terminal part of its precursor form, the anti-proANP. And this peptide self-assembles into amyloid-like fibrils in vitro. And the ANP, which is a hormone synthesized and secreted predominantly by the atrium or atrial cardiomyocytes, can have a high local concentration of this precursor protein, which can contribute to the formation of the amyloid. So the increase in the ANP production and accumulation may be enhanced by atrial stretch, as we all know. Could be due to diastolic dysfunction, could be due to valvular heart disease, especially mitral valve, and or atrial fibrillation. So the increased ANP production, which is meant to normalize the hemodynamics through natriuresis and vasodilation, ultimately becomes a maladaptive process, and the ANP tends to accumulate in the atria. So the fibrils are most frequently located extracellularly, especially along the cell membrane of the myocyte, but small deposits have also been found intracellularly. And it has recently been reported that the pre-fibrillary species can be cytotoxic and can have electrophysiological effects in the atrial cells that promote arrhythmia. So on imaging, there are no pathognomonic or characteristic findings, but on echo and cardiac MR, we can appreciate atrial wall thickening and atrial enlargement. And in one case report, they have shown diffuse enhancement of the atrial wall, as shown here. We've had 2 cases of confirmed isolated atrial amyloidosis at the Heart Institute, and none of them had such an enhancement on cardiac MRI. So it may not be something we see commonly in these patients. And the amyloid deposit can infiltrate both atria, so both atria can be involved. The diagnosis is based on histology and tissue subtyping with immunohistochemistry or mass spectrometry. The figures here shows the histological features of atrial amyloid deposits, which do not differ much from the atrial involvement with ATTR or AL amyloid, including on conglomerate staining and with the typical green birefringence in polarized light. And for such reason, antibody-based techniques such as immunohistochemistry or immunoelectron microscopy will be required to demonstrate the ANP deposits. Studies have shown association between histopathology confirmed ANP amyloid with heart failure, atrial fibrillation, and increased thromboembolic risk. But again, most of the studies are small size, sample size. One study, for example, revealed positive correlation in permanent atrial fibrillation, but not with paroxysmal atrial fibrillation. And also the progression and consequences of the isolated atrial amyloid could be influenced by pathological conditions, which may increase the secretion of ANP, loading conditions such as valvular heart disease, as I've said before. If we look at the clinical implication, for example, in this case report of a male patient in his 80s that has a history of atrial fibrillation and diastolic heart failure, who presented with symptomatic sinus node dysfunction on endomyocardial biopsy of the interatrial septum and immunohistology, they confirmed the diagnosis of the atrial amyloid. And on electroanatomical right atrial voltage mapping, they were able to identify the disorders of impulse formation and conduction within the atrium. So this is to prove that this condition can be responsible for atrial conduction abnormalities. Another study where they had right atrial appendage excision done in over 200 patients undergoing open heart surgery. Isolated atrial amyloidosis was found in about 16% of them. And compared to those that underwent a bypass graft, it was commonly found in those that underwent mitral valve surgeries. And the association between atrial amyloid was shown with atrial fibrillation and prolonged P wave duration, independent of age and sex. But atrial fibrosis in these cases was not found to be a predictor for atrial fibrillation. And the amount of the amyloid correlated inversely with the degree of interstitial fibrosis, interestingly. And this study concludes that it's associated with atrial fibrillation and affects atrial conduction. Another retrospective study on a total of more than 100 patients undergoing left atrial excision, left atrial appendage excision, out of which 15% were found to have the isolated atrial amyloidosis. So their preoperative characteristics with those that have the amyloidosis was not, and those that don't, were not different in terms of comorbidities or Euroscore or indication for surgery. A significantly greater proportion of patients with the isolated atrial amyloid were found to experience dysrhythmia requiring implantation of permanent pacemaker. And also the study, although it wasn't powered to assess survival, those that had the isolated atrial amyloidosis had significantly elevated incidence of perioperative death and inferior 1-year survival. So the take-home message is that one, it is localized, it's a disease that's localized to the atrium, and it does not, the amyloid fibril in this case do not infiltrate any other part of the cardiac structures. And the progression of the disease and its pathogenesis is very much linked to loading conditions, commonly mitral valve disease and persistent atrial fibrillation. Diagnosis, for the diagnosis, histopathology and immunochemistry of the tissue is required to establish it. And there are no specific therapies that exist for this condition so far. And management is more focused in controlling the rhythm disturbances. And there are no clear impacts about survival based on the studies so far. So thank you very much, and open for any questions.
Yeah, great. Thanks, Betty. That's a wonderful presentation and very interesting. I feel like with the rise of ATTR, it's one of the many forgotten amyloidoses so it's good to have a review. Any questions for Dr. Mengesha? I'm embarrassed to say that we actually don't have any that we are actively following in our clinic. We had a couple a few years back that we knew of who were found through cardiac surgery. Both of them eventually passed away just of old age. Yeah, rare entity. Maybe I'll just ask you one question, Betty, and put you on the spot a little bit. Is this something we should care about? Is it more of kind of an academic curiosity? What do you think? What do you think of this amyloidosis?
Yeah, that's a great question. So the reason that we wanted to present this because we encountered requisitions to on cardiac MR for such patients. And this is just, as you mentioned, more of an academic curiosity, just to create awareness. I don't think, although it does have clinical implications, as I've mentioned, with dysrhythmias and so on, I don't think it's clinically relevant for now. For one, we don't have much to do with it. And two, the diagnosis requires, like, as I said, histopathology. And I think it's a very common condition. It's just that it's rarely diagnosed because it requires biopsy. Yeah. So I don't think it's that relevant for now.
Yeah, I think you're right. It's probably underdiagnosed, but not going to change management for now, but important to be aware of. And, as we've seen, lots of research and advancements in amyloid in general. So you never know what will be around the corner. So great. Well, thanks again to both of our presenters. And I think now we can move on to the next session of our time today. So I'll hand it back to Dr. Small.
Thanks, Nowell, and thanks, Betty and Waseem, for those great case presentations. It's my great pleasure now to introduce Kareem Morant, who's an echocardiographer and assistant professor at North York General Hospital in Toronto. Dr. Morant, after completing his cardiology fellowship in the U of T, he completed his advanced echocardiography fellowship at the Mayo Clinic. He's currently the director of Heart Function Clinic at North York General Hospital, and is a member of the transcatheter heart valve team at Sunnybrook in Toronto. And he has a diverse interests in cardiac imaging, valvular heart disease, heart failure, and the ATTR cardiomyopathy. And he's particularly interested in how ATTR affects the Canadian Black population. He also involves teaching and is passionate about advocating for improved diversity and inclusivity in medicine. And Kareem and I have interacted a few times, and it's always a pleasure to speak with him and hear him talk. So thanks very much for agreeing to present today, Kareem. Just still on mute. Thanks very much.
Thanks, Gary. Thank you so much for the introduction, and thank you for inviting me to all of you. Organizers, we really appreciate the opportunity to talk about them. So, in the yeah. My presentation.
Yeah, there might be a problem, Kareem, with the audio, at least for me. Your voice is very choppy and we don't hear you very well. I don't know if there's a different audio you're able to use or if that's the only one.
Probably is it better now?
No, it's the same.
It was fine earlier, Kareem, when we heard your question, when you asked the question, it was fine then. So I'm not sure if it's a mic lead in or.
Just fine.
We've lost you. Sorry.
Can you hear me better now? No. It's just working.
I don't know. The only thing I can suggest is turn it off and turn it on, like log out, log back in. I don't know.
Let me try that. Let me try that. I muted and muted. Okay.
The other thing, Gary, to consider is if his audio, while he's fixing that, I don't know if you can do your talk first.
Sure, absolutely. Happy to. Should we do that, Kareem? Is that okay? Yeah. So Kareem's, I think, it's logged out. I'll share my screen. That's great.
I can introduce you.
Thank you.
Yeah. Sorry for the technical difficulties, folks, but yeah, we'll give Kareem another chance to fix things. And yeah, in the meantime, it's my turn and my pleasure to introduce my friend and colleague, Dr. Gary Small, and my co-chair for this session. Dr. Small is a cardiologist and clinical investigator at Ottawa Heart Institute. Kareem, we're just going to go ahead with Gary's presentation first, and then we'll give you a try. Does that sound okay? Yeah, okay. Dr. Small's research and clinical interests include the use of cardiac imaging to support clinical decision-making, in particular, imaging strategies to identify oncology patients who are at risk for cardiovascular disease and cardiotoxicity from chemotherapy. He's also interested in predictive value of imaging and plasma biomarkers for cardiovascular outcomes in chemotherapy-induced heart disease. And he'll be talking today about inherited ATTR is becoming more familiar, penitence, presentation, and detection update. So thanks, Gary. Take it away.
Thanks very much. Can you see my slides okay?
Yep, we can.
That's great. So thank you very much for the opportunity to present. And it's wonderful to kind of bring work with the community of amyloid doctors across Canada. This is my disclosure slide. So we wanted to kind of focus on this part of the session really on inherited ATTR. And in particular, in the next sort of 20 minutes or so, we'll talk about a particular branch of inherited ATTR cases. And those are individuals that are referred to clinic because they're genetically positive, but haven't actually manifested the disease yet. And we know that inherited ATTR is a rare disease. It has a 1 in 100,000 prevalence. And these patients are either coming to clinic because they've undergone genetic testing following the diagnosis of the disease in a relative, or we've even had some patients present after doing 23andMe and finding they have a variant ATTR genetic mutation. And when they come to clinic, they usually come with 4 questions. And that is, am I likely to develop the disease? What's the disease penetrance? They then might ask, well, what kind of symptoms might I expect? So how does the disease present? Then they can ask, well, what are you going to do to help me find the disease or to look for the disease? So that's detection. Then lastly, are you going to follow me in the long term? What's the strategy for monitoring my condition? And that's really in the field of surveillance. And what we'll do is we'll look through those 4 questions. We're a little bit out of sync, and I'm very wary of taking too much of what I know that Dr. Morant's going to speak on. So I'll keep some of this introduction very, very brief, not to sort of spoil some of what he wants to talk about. But there's roughly 140 genetic mutations in the ATTR gene. And we know that those different mutations will present with different phenotypes. So this mutation here, the Val30Met mutation with early onset, is predominantly a neuropathy type of ATTR, whereas the valine-122 isoleucine mutation is predominantly more cardiomyopathy-based phenotype with some mixed element. The other thing is that we know that there's quite different prevalences in different geographical mutations. So the Val30Met mutation was perhaps originated in Portugal. So we see this in Europe and where the Portuguese traveled to, into South America and also in the Far East in Japan. Whereas we see the valine-122 isoleucine possibly originated in West Africa. And Dr. Morant's going to speak more about the distribution of that mutation in due course. So when we look at our clinic's population of these patients, we do find that the valine-122 isoleucine mutation is the most prevalent within our population. About 6% of our patients have that mutation. We also see a smattering of a mutation that is believed to originate from Ireland and Germany. That's the thymidine 60-alanine mutation. Not surprisingly, in our cardiac amyloid clinic, most of our patients have either cardiac symptoms alone or are a mixed phenotype. But we do follow patients who are phenotypically negative. So they have the genetic variant but don't have disease, and about a quarter of our patients with variant ATTR fall into that category. I wanted to introduce this schema. This schema has been proposed in heart failure and also in valvular heart disease, where we notice that patients can be at risk of disease. So that these patients are stage A, where obviously in terms of what we're looking at today, they have a genetic positive mutation in the ATTR gene, but they can progress through these other stages of the disease. So when one of our patients who's got the genome comes to clinic, they want to know what's the chances of me progressing to, if you like, a non-cardiac stage of this disease with carpal tunnel syndrome, spinal stenosis, or ocular manifestations of the disease, and then further on as the disease progresses to developing cardiomyopathy or advanced heart failure. And we know that this variant ATTR has an autosomal dominant inheritance, so there's a 50% chance of being passed on from a parent who has the condition. But we also know it seems to have variable penetrance, so not everybody will develop the disease with this genotype, with these different mutations. We also know that penetrance, the kind of manifestation of the disease, varies between different mutations, and it appears to be age dependent. And we have increasing evidence regarding penetrance for the valine-122 isoleucine. So we're going to learn very shortly that the valine-122 isoleucine variant is probably the most important mutation in North America. What these investigators did was, this is an early study, the Jackson Heart study of 5,000 patients, and they genotyped about 3,000 of them. And these patients were just self-identified Black adults without heart failure. And their average age was about 55 years of age. And they found a prevalence of 4% of this variant within this non-selected population. And then what they asked us, well, what happens as these patients ages? When and if do they develop heart failure? And what you can see here over a long follow-up, median follow-up of 12 years, that after about 10 years, they began to see those patients who were genetically positive for an ATTR mutation had an increase in the prevalence of heart failure. And this increase after 10 years coincided with them reaching about 65 years of age. You can see the inflection point on the curve. And so they found that heart failure was prevalent in about 10% of these patients. So the penetrance in this cohort seemed to be about 10% after 10 years roughly around about the age of 65. The problem with the Jackson heart failure study is they never really confirmed that those episodes of heart failure were due to ATTR cardiomyopathy, and of course there are other causes of heart failure. So this study is a more recent study. It's a smaller study of 300 self-identified Black or Hispanic individuals, but they enriched this population by choosing a slightly older group, and they also had increased wall thickness on echo. And so these investigators then decided to genotype and phenotype these patients with echo pyrophosphate imaging, and we're looking for the valine 122 isoleucine mutation. So they found a higher prevalence in this population of the genome, but that's not surprising because they'd enriched their population slightly. But they also found that about 7 of these cases actually had ATTR cardiomyopathy. So the penetrance in this population was 40%. The best data, though, we have on penetrance of a variant ATTR is from the THEOS study. And this study will be increasingly become familiar to those of you who work within the amyloid sphere. So THEOS was a very, very ambitious undertaking. It began in 2007, and it was an undertaking of 30 different centers in 19 countries. And what they did was the investigators recruited or enrolled patients with wild-type ATTR, clinically apparent variant ATTR, and also they enrolled asymptomatic variant ATTR gene carriers, which is pertinent to our talk. And this data looks at 700 of those variant ATTR asymptomatic patients. And what they did was they divided them into 2 groups. Because this was a very European-centric study, you'll see that the predominant number of patients in this group are the Val30met, the Portuguese mutation that we talked about. But really, sort of focusing on our own population here, we might want to focus on this group here, which is the non-Val30met. So these would be like those valine 122 isoleucine mutations. And what they found was that penetrance in the non-Val-met group was about 43%. They also found that the penetrance occurred at an older age in this group versus in the Val-met group. And they found that overall penetrance was more frequent in males. So after 6 years of follow-up, there were fewer males that were asymptomatic overall. So this is quite useful information. So we can see that in the most common genotype that we're going to be referred in clinic, that our penetrance is probably somewhere between 10 and 40%, depending on the population studied. The cardiomyopathy presentation will typically be beyond the 65 years of age, and penetrance may be lower in females. The next question, if you remember back, was, well, what sort of symptoms might I develop? How might the disease show itself? What should I be looking for? And again, we can look at that data from the THEOS study to help with that question. And again, if we divide the patients into sort of the European mutation in blue, and then the kind of North American or other mutations in yellow, what you can see is that patients tended to actually have a high frequency of neurological presentations. So they were asymptomatic at enrollment, and as they were reviewed each year, as they asked questions on that, they found that patients had a high frequency of neurological symptoms, almost in 50%. For the other 50% of patients, what did they present with? Well, about 25% had cardiac symptoms, which are listed here, and about 25% actually in this non-Val-met group actually developed carpal tunnel syndrome. And this speaks to the importance, and I'm sure that other amyloid clinics do this as well, but we have to expand our examination of patients now to include, a very important look at carpal tunnel signs and symptoms within our amyloid patients. We talked about different penetrance between male and female patients, but this also speaks to different symptoms that males and females might complain of when they come to clinic with variant ATTR. And you can see here that ladies tend to have a higher prevalence of predominantly neurological findings versus males, whereas males tend to have a higher frequency of predominantly cardiac versus females. So there may be slightly different symptoms depending on whether they are male or female. So in answer to the question is what is likely to happen to me, neuropathy is common, and although in this schema down here, you can see that for the valine-122 isoleucine, this common mutation in North America, that cardiomyopathy is often what we see, we do know that these patients also suffer with neuropathy. So it's important not to forget that when we see these people in clinic. And secondly, that there are probably differences between male and female in terms of how they might present, what symptoms they may develop. Females may have more neurological development and males may be cardiac or mixed. So what kind of testing can be done to look for the disease? I won't spend too long on this, these pictures, but these are classical echo findings in advanced ATTR cardiomyopathy. You can see the concentric left ventricular hypertrophy, the right ventricular hypertrophy, the thickening of the AV valves, both the tricuspid and mitral, and the severe bilateral atrial dilation. The trouble is this is advanced disease, and of course, what we're interested in is these asymptomatic gene carriers. So the problem with echo is the current criteria may not detect asymptomatic disease because it relies on structural changes, and that requires significant fibril accumulation. And in order to detect disease more sensitively, we might require a more sophisticated approach. And that approach, you may have heard Dr. Fontana speak about this morning. She spoke very eloquently about the utility of cardiac MRI to detect and monitor disease. CMR will also pick up structure, just like echo, but it can assess what we call tissue characteristics. And this is useful because the amyloid fibrils infiltrate into the myocardium. Dr. Fontana dwelt on this a little bit this morning. Amyloid fibrils infiltrate in the extracellular space in ATTR cardiac amyloid. So we can, if we measure that extracellular space in terms of the extracellular volume, we can get a window on how advanced the disease is. The more extracellular volume, the more amyloid protein, the more advanced the disease is. And in this study that wasn't performed in ATTR, we got a window on the utility of using cardiac MRI to pick up preclinical disease. And they compared cardiac MRI with echo versus serological markers. And in this small study, there was no ability with serum to pick up asymptomatic disease. Echo was only picked up 20%. But you can see by using ECV with cardiac MRI, they were able to pick up 70% of cases who had preclinical amyloid deposits. Not everybody. So we do this clinically in our patients. We track their ECV. This is a lady who's a valine-122 isoleucine carrier, and she was enrolled in clinic in 2020. We measured her ECV at MR to be 26%. Troponin was 19. She did have carpal tunnel syndrome in 2022, and we'll talk about whether or not, how do we manage this presentation with signs of amyloid, but not yet cardiac or neuropathy findings. So we're continuing to track her. Pyrophosphate remains negative, but her troponin has now increased to 46 and her ECV is 30. And the utility here might be to help define the frequency of surveillance as we watch ECV, waiting for some of these therapy-defining traits to reveal themselves. Now, everybody has access to MRI. So this has prompted some work that we've been doing, and I know that other groups do this too. This is not to compete with MR, but it's to provide an alternative. Most centers have cardiac CTs or have CTs that are capable of acquiring this type of imaging. So if there's a CT scanner where you work, is capable likely of obtaining this type of information. We can measure ECV using CT, and CT-derived ECV correlates very closely with MR. So it may be possible to track some patients with CT. And the radiation doses that this type of CT imaging uses as low as by 5 millisieverts per scan. Of course, in terms of detection of the disease, the most important non-invasive test is the pyrophosphate or bone scintigraphy. And this was demonstrated in this landmark study by Gilmore and colleagues. But one of the questions about bone scintigraphy is particularly relevant to our patients, our asymptomatic gene carriers, is how much protein do they need before that pyrophosphate scan will be positive. So how much protein, how much amyloid protein do you need before the pyrophosphate will be positive? And one of the ways you can look at that is to look at, what level of ECV on MRI is a pyrophosphate then found to be positive. And we found that we've had a positive pyrophosphate scan right down as low as 32% ECV. A normal ECV is somewhere probably between 26 and 28 for a middle-aged individual. So this is a very sensitive measure then, given that we can find a positive pyrophosphate even with an ECV of 32. Other groups have looked at using pyrophosphate scanning to screen asymptomatic variant ATTR. There is an issue, however, that we do need to be aware of. One of the issues is that there are rare variant ATTR genotypes which may be falsely negative on bone scintigraphy. And the reason for this is that some genotypes produce fibrils that don't retain this tracer. So wild type and most genotypes produce fibrils with assorted lengths, type A, but there are rare genotypes that just produce full-length big fibrils that don't retain pyrophosphate. And we know some of those genotypes, but not all of them. And so the point is, if you have a patient with one of these genotypes, their pyrophosphate may be negative despite an increasing ECV on CT, and you may need to perform a myocardial biopsy on those to confirm that there is indeed cardiac amyloid. So just be aware, I think, in terms of these genotypes, that the pyrophosphate scan may be negative. This literature is much more better described for the European radial tracer, that's the BPD tracer, because of the prevalence of this genotype within Europe. Finally, what is the future in terms of screening, in terms of non-invasive screening? I didn't demonstrate the whole of this paper to you earlier on when I showed you with the sensitivity of CMR to pick up sort of subclinical amyloid deposits. The best and most sensitive measure we have is F18 or these thioflavin PET compounds which bind to beta-pleated sheets. They're not in clinical use at the moment. They are used in research purposes, but they're exquisitely sensitive for picking up extremely low levels of protein. And it may be that in the future, this is how we will perform surveillance of our gene carriers for ATTR. Of course, all this information about screening of patients is predicated on the idea that early therapy is more effective in terms of improving outcomes. Is there any evidence for that? Very briefly, I'm not going to talk long about treatments, but there is some evidence to suggest that early therapy is better. You will be aware of the ATTRACT trial. And in the ATTRACT trial, tafamidis was used in both wild type and variant ATTR versus placebo. And that's the first part of this graph here into this dotted line. And what they showed was that those patients on tafamidis had a 30% relative risk reduction at 30 months. The authors were very clever. They then recruited about half the patients on tafamidis to continue on tafamidis, and they managed to get about half the placebo patients to continue within study follow-up, but transferred them to to tafamidis therapy. So, and then what they did is they looked at outcomes at 60 months, and they found that this 30% relative risk reduction actually became 60% became 40% at 60 months. And there's several things to look at in terms of whether or not early treatment is better based on this picture. The first is perhaps to reflect on the extrapolated placebo. So they did some modeling, and you can see here that when treatment changed back here, that those patients who had extrapolated placebo did worse. But this is just modeling data. Far better to look at the difference between the blue and the orange lines. And you can see here that had those placebo patients begun treatment much earlier, then they would have had much better outcomes. So these graphs really speak to the idea that earlier treatment is better. They also found that in terms of symptoms, if you look at NYHA class in this bottom table here, you can see that those patients who were NYHA class 1 to 2 had much better outcomes versus those who were NYHA class 3 at enrollment. So earlier treatment is better. We come to that last question. Hopefully we're okay for time, but we come to that last question, is our long-term strategy for monitoring my condition? There are a few consensus articles now from different groups regarding how we should monitor patients. This is a consensus statement from a Japanese consortium. So several different amyloid groups within Japan got together and wrote out this very comprehensive schedule. I'm not suggesting this is something that we should all do. In part, their schedule reflects the prevalence of the valine 30 MET mutation within their population. Two things I would point out. One is that the idea at the bottom of the chart here about genetic counseling. Often we think about genetic counseling as something that we do at genetic screening and then we don't do it anymore. But of course, that's not the best way to do it. Genetic counseling should be done every year as we discuss evidence that's arising with regard to penetrance and phenotypic kind of traits that patients may develop. The other thing to point out is the information sharing of treatment options in clinical trials. And as the data comes out with newer techniques such as CRISPR technology or depletion, these may be bits of information that are important to share with families. This is a more wide or global consensus article from both Japanese and European authors. And what I wanted really to show you in this chart was this concept of predicted age of disease onset. We talked earlier about perhaps 65 being an important age for those who've got the valine 122 isoleucine mutation. But you can see that the typical age of disease onset has been characterized for many mutations. And the rationale here is that we enroll patients in our clinic, but we would and take some baseline measurements, but then we really start concerted follow-up 10 years before that predictive age of disease onset. And as patients might get non-therapy defining traits, we might then put them in this high-risk category with more frequent surveillance. So to add to this schema, we do need to note that certainly in Ontario, that we don't have a therapy for these patients that's disease modifying. We can treat their carpal tunnel, their spinal stenosis, refer them to ophthalmology for the vitreous deposits. But we don't have access to agents such as difluzinol, which might be an option in this group. And we have to wait for them to develop cardiac amyloidosis or peripheral neuropathy before they get therapy permitted features, if you like, so we can then give disease-modifying treatment. So what are the next steps for these patients, the variant ATTR gene carriers? I think that we can begin to advocate for stage D disease therapy with treatment like difluzinol. It's not available in Canada, but it might be a cheap option in order to potentially stave off the development of those therapy-defining agents, but more data might be available in time for that. I think you'll see greater use of cardiac MRI and or CT to track ECV. Whether cardiac PET becomes into use will depend on the availability of PET traces. One of the things that we're not great on, and Dr. Morant may speak a little bit about this, but about pedigree completion, because of the dispersion of patients with some of these variants, it can be difficult to track down family members. There is a desperate need for more genetic counselors within all rare diseases, but I think particularly to offer these annual follow-ups. And you'll have seen from most of the slides the importance of having access to an enthusiastic multidisciplinary team. So we began by asking these 4 questions, and trying to address them so that we might be better armed when patients come to clinic and ask, are they likely to develop the disease? How might the disease show itself? What can be done to look for the disease? And is there a long-term strategy? So I hope that if at the beginning of the talk you were not familiar with ATTR, I hope at the end of it that you are a bit more familiar now. Thank you very much for your attention.
Great, thanks, Gary. That was a fantastic overview and highlighted a lot of important issues and topics and gaps that are continuing to develop over time and need a lot of knowledge studies to help fill some of those gaps. But really nice talk, and I'm just wondering whether it might be best if we kind of roll right into Kareem's talk next, if you think that works, and then maybe have a little bit of time for discussion and questions on both topics after that. Does that work for both?
Good idea. I hope, sorry, Kareem, I hope I haven't said too much.
No, can you hear me?
Yeah.
Yeah, fantastic. No, that was fantastic, Gary. I apologize for the technical difficulties. I'll try to fill in my part here now. Let me see here. Here we go. And we need to just share screen. This was working before, so. PowerPoint. Can you see my slides now?
No, it looks like you're sharing your screen, but it looks like we're only seeing the top, it looks like the top banner of the PowerPoint
Oh.
file.
Still not seeing anything?
No.
I switched to my laptop. Okay. Let's see.
Oh, there we go.
Better?
Yeah, now I can
All
see.
right. Fantastic. Sorry about that, guys. I apologize, Gary. Fantastic talk, as expected. Hopefully I can fill in some of the blanks for those of you who didn't get necessarily the full background. So I'm going to talk about hereditary ATTR in the Canadian landscape. So here are my disclosures that are relevant. So here are the objectives. I want to give you a background about ATTR cardiomyopathy. I want to give you an understanding through a case. And then I wanted you to hear a little bit about the Canadian Black population, which we actually don't have a lot of data on. And then I'm going to discuss the 3 most common genetic variants that you should know of, and Gary already hinted at some of them. So let's talk about a case. This is a 66-year-old female who had an abnormal echocardiogram showing concentric left ventricular hypertrophy and increased LV mass. I saw her a few years back now, and her echo was actually done for a checkup. Family doctor said, you actually haven't had an echo for a while, so let's do it. And so she has a history of hypertension since her 20s, very common in the Black community, as you may know. She's had hypothyroidism. She actually had carpal tunnel syndrome with bilaterally with previous carpal tunnel release 10 years prior, with actually worsening symptoms by the time that I had seen her. She has a family history of her mother passing of natural causes in her 50s back in Trinidad, where she's from. Her medications are bisoprolol 2.5 milligrams, chlorthalidone, and Synthroid. She's a retired energy construction worker. She's highly active, is a Zumba dance instructor 5 times a week when I met her. And so she was asymptomatic from a cardiovascular perspective, and I told you about the hand numbness that was worsening. She actually, her physical exam, she was much younger than her stated age. She looked as if she was in her 40s. She was normotensive at the time, and her echocardiogram is as follows. And so here's her echocardiogram. You can see here significant left ventricular hypertrophy, thickened valves, wall thickness measured between 15 to 16 millimeters. There's also, if you look at the annular motion in the 4-chamber view, there's significant diastolic dysfunction. And so this was very suspicious for me, because this is a lady with hypertension, but only on 2 antihypertensive agents with well-controlled blood pressure. So the lights really went off for me in her case. And so we did some other investigations. Her ECG showed borderline R-wave progression and no criteria for left ventricular hypertrophy. Again, another red flag to me. And then her echo with strain showed the classic cherry on top. It was overall normal global longitudinal strain, but there was definitely an abnormal apex to base ratio of strain. And so let's change gears here and talk about the background. We talk about the transthyretin molecule, which is also known as prealbumin. It's a tetramer that is a carrier protein for thyroxine and hollow retinol binding protein. It's secreted in the liver and the thyroid plexus. And the actual protein is encoded on the TTR gene located on the 18th chromosome. And so here's the basic pathophysiology. I think many of you have already know this, so we'll be brief. But in general, as I mentioned, it's created in the liver in a tetramer, and then you have misfolding, and then it leads to small oligomers, which then aggregate into amyloid fibrils which are then deposited into organs, which lead to organ dysfunction. And so we should also talk about the terminology. Here, there are many different names. It's important to understand that. We have transthyretin cardiac amyloidosis, transthyretin cardiomyopathy, and then we have mutant ATTR or hereditary transthyretin-related amyloidosis, or also previously known as familial amyloidosis. In general, we know that there are different types, but please remember that wild type is more common than hereditary, as Gary was mentioned before, and we're going to focus on the hereditary form on the left here. This is a brief slide just to remind everyone that it's really a systemic disease. There are multiple manifestations, and so important to screen for these, and we'll talk more in detail about the specific genotype that have specific phenotypic presentations. And so this is an important slide outlining some of the over 100 genotypic mutations in the amyloid protein. We can see here the ones that we're going to talk about, which are highlighted: V122I, which is also known as V142I, which has a predominant cardiac phenotype. And also in the middle, we have V30MET mutation, which Gary talked about too as well, which has late onset and a mixed phenotype, but mostly cardiac manifestations, whereas there's a V30MET mutation, which is early onset and has almost exclusively neurologic involvement. And then T60A, which we'll touch briefly on as well, has more cardiac involvement, but some neurologic involvement as well. So let's move on to talking about the Black population and ATTR and how they relate together. And so just so you all know, I mentioned V122I. You'll see that in the literature. It's now sort of been changed to V142I. You can think of them exactly the same. And so, as Gary mentioned, when you look at V142I, if you look at Black populations in multiple populations across the world, if there is a ancestry related to West Africa, you will find approximately 3 to 4% of that population being positive for V122I mutation, which is quite remarkable. And here, this is a study here that looked at varying populations across the United States, and this population percentage stays true throughout. And so we have to ask ourselves why that is. And so obviously the influence of the transatlantic slave trade many generations ago has a major influence. And so obviously West Africa was the hotspot for the removal and transportation of slaves. And so in the United States, we see large populations of V142I positive mutations. And then also we see large populations in the UK, and we also see large populations also in the Caribbean. Again, all hotspots for the transatlantic slave trade. And then also we have specific migration patterns, which we'll talk about too, which also explain this. And so when we look at this study, which was a review study in Circulation, you can see that across the United States, there's highlighted about 3 to 4% population of V122I mutation. And then we see when you study your specific ATTR population, you end up getting anywhere from 50 to 60 to 70% of the variant forms being V122I or V142I mutation. And so really, as you see on the right, the percentage of people that are variant will depend on the proportion of your population that is of African descent, particularly West African descent, I should say. And so when we look at the demographics of the V142I mutation in this review, basically you could think of it almost exclusively occurring in people of African descent who are usually self-identified as Black, but there are obviously some exceptions. There's a male predominance, The age of onset is about 63 years old. Diagnosis comes later, between 67 to 70 years. There's a high predominance of atrial fibrillation, which I do see anecdotally. I would also add here, in some populations or some studies, we do see a high predominance of carpal tunnel syndrome, up to 50%. And then in terms of clinical outcomes, there's an increased incidence of heart failure in carriers, and there's lower reported survival, which we will also touch on. And so this is a nice other study looking at specifically the African population. They looked at the allele frequency, and again, there were hotspots of this allele in Western African countries, including Nigeria and Ghana, etc., with lower allele frequencies in the southern and eastern countries. This is a very interesting study published most recently just last year, and I think presented at AHA, if I remember correctly. And this looked at the Women's Health Initiative and looked at actually 300 carriers of V122I mutation compared to non-carriers, all self-identified Black females. And when they looked at that, they found that, as expected, 3.4% of the population had V122I mutation. And then there was a 50% increased risk of cardiovascular disease, 2 times risk of heart failure, 80% increased risk of coronary heart disease, and a 70% increase in cardiovascular death when you looked at carriers versus non-carriers, and all-cause death at 30% increase. So this gene definitely seems convincingly pathogenic when we compare to non-carriers, and this was a female population. And so when we look at a specific study here, now a few years back at the National Amyloid Center in the UK, their population, they found that they have a large Caribbean population in the UK, and the median survival for V122I mutation was about just over 2 years, 31 months. So there's convincing evidence that this mutation is quite pathogenic and carries the worst survival. And so the question you may be asking is, well, how does this relate to the Canadian population? And so there's a large population of Black Canadians here in Canada, and we occupy about 1.5 million across Canada, and that's just under 5% of the population. More than 40% are born in Canada, and we're not a monolith. It's a monolith, as there are varying ethnic and cultural origins for the Black population across Canada. And when we look at the population, as I mentioned, very heterogeneous. A large population, part of the population originates from the Caribbean, as well as now increasing numbers coming from Africa, as well as smaller numbers from the Americas, as well as Europe. So this is very important when we think about the populations across the country. And so this comes from Statistics Canada. You can see when we look at the Black population, the largest population or community is in Toronto, and I would expand that to the GTA as well, with Montreal, Ottawa and Gatineau as close following populations. And actually the fastest growing population is actually in the prairies. So there are populations all across the country that I think it's so important for us to be aware of. And so we don't have the data yet to tell us exactly what the incidence of or the prevalence of this mutation is in Canada. I hope to study that. But I make the analogy that we probably are most closely analogous to the UK. And so when we look at the population, there's about 4.5% of the British population is from the Afro-Caribbean descent, and that's about 4.3% here. And I would say in Toronto, there's numbers anywhere between 8 to 13% of the population is of Afro-Caribbean descent in Toronto, whereas actually in London, it's about 13%. over 1 million Afro-Caribbeans are in London, UK. And so very similarly as well, we have a high percentage of Caribbean patients or Caribbean people in Canada, particularly in Ontario. 50% of the population is from the Caribbean. And this one touches home. 34% of that population is of Jamaican descent. I am of Jamaican heritage. And so when we look at similarly in the UK, we see the similar makeup of the population. And so other variants you should know about is V30 MET and T60A. V30 MET, as Gary had mentioned before, is what was previously referred to as the Portuguese phenotype, as it was first described in Portugal. This is an autosomal dominant inheritance pattern with varying penetrance. There's 3 major endemic regions where we find this mutation: Portugal, Sweden, and Japan. There are 2 main phenotypic features, as I mentioned. There's one that's early onset that occurs at less than 50 years old, which is predominantly neurologic in nature with small fiber neuropathy and autonomic dysfunction. There is some kidney involvement with nephrotic syndrome and actually ocular involvement, which was new to me. And survival is actually about 10 to 20 years from onset. And then whereas there's a late onset phenotypic V30 MET group, and they tend to develop disease after the age of 50. And it slowly progresses with polyneuropathy, but there are some cardiac features with heart block and heart failure. Median survival is estimated to be about 7 years in some reviews. And so T60A is also, or also known as T80A mutation, is important. It's the second most common mutation in the United States. It originates in Northern Ireland, and it's also referred to as the Appalachian mutation in the US, seeing that it's found in the Appalachian region. There's mixed phenotype, and there's high rates of carpal tunnel, estimated to be above 70%. And often carpal tunnel is the first manifestation. The disease onset is often particularly neuropathy, and often after the 4th decade in life, with a strong male predominance, 3 to 1. And so this last study compares some of the genotypic mutations that we were talking about. This study, we looked at over 1,200 patients with ATTR amyloidosis. This was in the UK at the National Amyloid Center. And what they found is that looking at the 1,200, most common, as we mentioned before, is wild type ATTR, with about 400 that are hereditary, and most predominant mutation V122I, as expected, large Black population, large Caribbean, Afro-Caribbean population in the UK, and then smaller numbers of T60A, and then much less others. And so what they found is that when they looked at the degree of severity in multiple different parameters, V122I had the worst disease severity, followed by wild type ATTR, and then subsequently T60A. So again, this really does highlight the fact that this disease, particularly V122I mutation, seems to be quite dangerous. And so I'd like to wrap up with the case that we discussed at the beginning, just to close the loop here. This lovely lady now, who's 72, actually, this was at the time when we really didn't have a PYP readily available, and she was one of the first to be enrolled through Diego Delgado downtown receiving tafamidis. And so she had a cardiac biopsy, it was positive, and then she had genetics were positive, V122I heterozygote. She was later found to have some spinal stenosis on screening, some mild pain with that. She's been okay. She is on tafamidis, as I mentioned. She continues very active lifestyle, loves to travel, still doing Zumba. She's on screening, we found paroxysmal atrial fibrillation. She's been anticoagulated, and now she has symptomatic PEF, becoming very much more symptomatic, and she's intolerant to amiodarone, which makes my life much more challenging. And I referred her for atrial fibrillation innovation. We can talk about it later, but the data is not necessarily positive for this, but really I'm grasping at straws to manage her. for her paroxysmal atrial fibrillation. And so in summary, the three most common mutations are ATTR for ATTR-CM in terms of hereditary ATTR is V142I. There's debate about whether that is the most common in the world. We could talk about that later. V30MET and TH60A. And so know your population. The Canadian Black population is heterogeneous. There are varying populations across the country. I touched on a few, and it's a rapidly growing and heterogeneous population, so important. The most common hereditary form in Canada, I suspect, is V122I, and it's seen in almost exclusively in Afro-Caribbean populations. And lastly, convincing data suggests that V122I or 142I is the most pathogenic form of ATTR, and so whether that's related to underdiagnosis, socioeconomic status, which is hard to tease out, or whether that's purely biologic, is up for debate. And happy Black History Month.
Great, thanks, Kareem. That's another fantastic presentation and lots of important things to think about, which you really highlighted nicely. I guess we have a few minutes for questions for Dr. Morant and Dr. Small. I have a couple questions I could ask you both, but I want to open it up to the audience first to see and give everyone else an opportunity. If you have a question, feel free just to ask it.
Hi, I have a question. My name is Echocardiographer. I'm a cardiologist, director of the amyloid program in Northwestern in Chicago. Excellent talk by Dr. Morant, Dr. Small. Question primarily is for Dr. Small. With regards to the asymptomatic carriers, I think that's an issue that a lot of us struggle with in terms of screening interval and when to just pull the trigger, especially for that patient that you presented, that you were tracking their ECV, whether to just check their prealbumin and just start them on diflunisal and see if there's a difference.
No, it's a great question. And I think actually she has relatives in the US. So that's exactly what I've done is I've asked her to try and source diflunisal. We don't have that available to us in Canada. But I think obviously, so for those who don't know, the diflunisal is a non-steroidal drug. So we have to watch renal function, we have to watch fluid retention, and warn about GI side effects, of course. And it may not be something we would do in a frail individual. But I think if those risks are felt to be low, then I think it's an excellent option. And I know that they use that a lot in the UK National Amyloid Centre, even as a conjunct with the silencer therapy. So there is some good evidence that on its own, it can help to stabilize the disease and the protein. So I think I think you know, if it's available, I think that's a very good option, particularly if they've got some of those what we've defined as non-therapy permitting traits. You know, she has manifestation now of systemic amyloid in carpal tunnel. So, you know, I think why not is because I think it's only a matter of time that she'll develop the cardiac. Obviously, you and I probably agree that I wouldn't do it before that. I was going to talk about prealbumin. So one of the interesting things about the SCAN-MP study was that one of the things that correlated with the positive pyrophosphates was low prealbumin. So the concept being, I know you were aware of this, but the concept being that prealbumin, it runs off on the gel before albumin. It is the tetrameric form of ATTR. So if you can't stabilize your tetrameric form, you'll have low levels. So we see low levels in those who have features. So as you rightly pointed out, that could be another indication perhaps to consider the diflunisal kind of therapies if they're available. You know, great point. Thank you. Thanks very much.
Thank you.
Yeah, great question.
The room might be closing, guys, in the next minute here, just to warn people. What would happen is everyone would be sent back to the main room, and there's a short survey we're going to ask people. But that was an excellent question. That was going to be my question as well, is what to do with the asymptomatic care. Do you follow these patients, Nowell, in your clinic, like genotype positive, phenotype negative? You do? Okay.
Yeah, we have a handful, and I think everybody, as was alluded to, is struggling to know what to do with them. We haven't been doing routine, surveillance with MRI. We've been using biomarkers, including TTR, although we don't really know very well how to interpret that either. And pyrophosphate every 3 to 5 years, depending on factors like patient age and their genotype and other risk factors. But it's still an area that's evolving. We need more evidence to guide us on. And therapy too. Out of interest, we may run out of time here, but there's an RCT that's starting up that's run by Eidos and Bridge Bio on the strength of acoramidis study being positive, which is going to randomize asymptomatic carriers to either acoramidis or placebo. It's a large study globally. It's probably going to run for many years because obviously events will be low in this population. But it could be an important piece of the puzzle. It looks like we're about to be broken out.
Yeah, I think there's a countdown here in 40 seconds. So maybe you guys can have the closing words here.
Yeah, well, I'll close us out if that's okay. Gary, thanks for co-chairing this session with me, and thanks again to Ian and the Ottawa Heart Institute for putting on this great event, and of course to our fantastic speakers for a wonderful session. So we'll see you in the big room shortly. Have a great day, everyone.